I'm Islam Shaheen, consultant psychiatrist in private practice, head of Cairo Mood Center, Cairo, Egypt. I'm the author of the Shahin Mixed Depression Scale, a self-rated instrument designed to measure the non-DSM mixed features in depression. I've been focusing and practicing mood disorders for more than 20 years. And in 2011, I attended a great debate about what's called the non-DSM mixed depression between two eminent speakers, Athanasios Koukopoulos from Italy, who died in 2013, and Alan Swan from America. Koukopoulos then proposed different set of symptoms other than those of the DSM-5 to characterize mixed depression. Since then, I have focused on these criteria, evaluated them in every patient presented to me with depression, be it unipolar or bipolar. I found these criteria very useful, clinically relevant, and frequently encountered to the extent that I thought I had to designate a scale to capture these important symptoms. I did, and the validation study of what's called the Shahin Mixed Depression Scale was just published 10 months ago. My topic today is measuring mixed depression, introducing the Shahin Mixed Depression Scale. The main items on our agenda: historical timeline, mixed depression review of the literature, clinical experience with what's called the non-DSM mixed depression, and Shahin Mixed Depression Scale. Regarding history, the famous psychiatrist Emil Kraepelin, together with his famous successor Wilhelm Wigand, thought that mixed states were the most common form of manic depressive illness. Kraepelin defined 6 types of mixed states, 3 of which were based on the 3 fundamental symptoms of mania, namely flight of ideas, euphoria, and hyperactivity. These are depressive mania, agitated depression, and unproductive mania. Depressive mania comes into being when hyperactivity and flight of ideas are combined with depressive mood. Agitated depression can arise if hyperactivity is combined with depressive mood and poverty of thought. Unproductive mania comes into being when hyperactivity and euphoria are combined with poverty of thought. The next 3 types of mixed states were based on the 3 fundamental symptoms of depression, namely depressive mood, poverty of thought, and weakness of volition. These are manic stupor, depression with flight of ideas, and inhibited mania. Manic stupor can arise if euphoria is combined with weakness of volition and poverty of thought. Depression with flight of ideas can arise if flight of ideas is combined with weakness of volition and depressive mood. Inhibited mania comes into being when euphoria and flight of ideas are combined with weakness of volition. These are the types of mixed states according to Kraepelin, and these are the most common forms of mixed states regarding the concept of manic depressive illness of Kraepelin. But the term bipolar disorder, coined by the German psychiatrist Carl Leonard, was officially introduced in the DSM-3 in 1980 in place of the Kraepelinian term manic depressive illness. As the diagnostic and the statistical manual nosology of mood disorders follows the conceptual system of Leonard and not that of Kraepelin, mixed states in general and mixed depression in particular have been neglected for decades. As you see here, the evolution of the diagnostic criteria of mixed states in the DSM editions. In the DSM-1 and DSM-2, there were no specific criteria. In the DSM-3, full mania and full depression, intermixed or alternating every few days. In the DSM-4, the definition was narrowed further, requiring simultaneous presence of full mania and full depression. DSM-5 made the problem worse. The term mixed states was replaced by the term mixed specifier. And according to the DSM-5, mixed depression is diagnosed by full criteria of major depressive episode and at least 3 of the following hypomanic or manic symptoms during the majority of days of the current or most recent depressive episode. Elevated mood, inflated self-esteem or grandiosity, more talkative than usual or pressure to keep talking, flight of ideas or subjective experience that thoughts are racing, increase in energy or goal-directed activity. By the way, do you remember what DSM-4 says about this criterion number 5? DSM-4 says increase in energy or goal-directed activity or psychomotor agitation, while DSM-5 says increase in energy or goal-directed activity, and there is no mention of psychomotor agitation. Anyway, criterion number 6, risky behaviors. Criterion number 7, decreased need for sleep. You can ask, where is irritability? Where is psychomotor agitation and distractibility? The answer is that these symptoms were considered overlapping symptoms, can be present in both mania and depression, so they were excluded in the DSM-5 criteria for mixed depression. Such a definition poorly reflects reality indeed. In a very recent study in 2020, that's the study of Bacchiarotti et al., it was reported that excluding the overlapping symptoms from the DSM-5 criteria has resulted in underdiagnosis of mixed features of depression. And in the study of Koukopoulos and Gabrielissani in 2013, why DSM-5 is wrong and so was DSM-4, it was reported that the frequency of mixed mood states similar to the DSM-5 ranged from 0 to 12%. On the contrary, when using a definition including psychomotor agitation, inner agitation, and irritability as central features, the frequency ranged from 33 to 47%. Practically speaking, excluding the overlapping symptoms from the DSM-5 criteria might increase the specificity of the diagnosis at the expense of sensitivity, as most individuals with mixed depression do present with these overlapping symptoms, as you see. So, how about mixed depression review of the literature? Take a look at this study. That's the study of Koukopoulos and Gabrielissani in 2014. DSM-5 criteria for depression with mixed features, a farewell to mixed depression. In this study, the authors reviewed the major works about mixed depression in both classic and modern literature. In classic literature, they reported that the classic authors described the clinical picture of mixed depression as characterized by irritability, distractibility, psychomotor agitation, racing or crowded thoughts, and over-talkativeness. Remember these 5. And there is no mention in classic literature of 5 of the 7 DSM-5 mixed features, excluding pressured speech and the flight of ideas. In modern literature, the authors reviewed the major works about mixed depression from 1994 through 2012 and found that there were 14 papers, including the papers used by the DSM-5 mood disorder working group itself. 7 of these 14 papers found that the most frequent mixed features were, do you remember those 5? Yes. Irritability, distractibility, psychomotor agitation, racing or crowded thoughts, and over-talkativeness. 3 of these 14 papers didn't find any of the DSM-5 mixed features as relevant for identification of mixity in depression. One study, that's the study of Vidrovich et al., who assessed 550 patients for 5 of the 7 DSM-5 mixed features, excluding pressured speech and the flight of ideas, and found that these 5 symptoms, these 5 DSM-5 mixed features were so infrequent, only ranged from 7 to 12%. Another study, that's the study of Peers et al. In 2012, who analyzed the data of 2,397 patients from the STAR-D study and found that there is an association between the DSM-5 mixed features and a greater likelihood of remission of depression, that's to say on antidepressants. This study reviewed the major works about mixed depression in both classic and modern literature up till 2012. How about the studies from 2013 up till 2021? Take a look at this study. That's the study of some Korean colleagues about the prevalence of the DSM-5 mixed features, a systematic review. In this study, it was reported that the prevalence of the DSM-5 mixed features of depression is 11.6%. And when the meta-analysis is confined to the studies with low to moderate risk of bias, the prevalence is 9.2%. So infrequent. So infrequent. So taken together, all the studies in classic and modern literature up till now might provide an evidence that supports the potential validity and the clinical utility of using a different set of symptoms other than those of the DSM-5 to characterize mixed depression. Consequently, alternative sets of mixed features were proposed by many authors. These focused on such mixed features as irritability, distractibility, psychomotor agitation, racing or crowded thoughts, inattention, over-talkativeness, mood lability, marked emotional reactivity, initial or middle insomnia, risky behaviors, and the like. Among such alternative criteria were those proposed by Cairo. He utilized the research diagnostic criteria of agitated depression as a mixed depression subtype, and validated another form of mixed depression. That's Cairo criteria for mixed depression. For depression with psychomotor agitation, Cairo recommended giving the name agitated depression as defined by the research diagnostic criteria. Full criteria of major depressive episode and at least 2 of the following manifestations of psychomotor agitation: pacing, unable to sit still, hand-wringing, pulling or rubbing on hair, skin, clothing, or any other objects, outbursts of complaining or shouting, and over-talkativeness. 6 symptoms. For depression without psychomotor, or for mixed depression without psychomotor agitation, Cairo recommended giving the name mixed depression. That's Cairo criteria for mixed depression. Full criteria of major depressive episode, and at least 3 of the following symptoms: irritability or unprovoked feelings of rage, inner tension or inner agitation or psychic agitation, racing or crowded thoughts, over talkativeness, rich description of suffering or frequent spells of weeping, absence of signs of retardation, mood lability and marked emotional reactivity, and early insomnia. 8 symptoms. So in sum, co-couple's proposal: depression with psychomotor agitation, depression without psychomotor agitation. Depression with psychomotor agitation, psychomotor agitation as defined by the research diagnostic criteria, 6 symptoms, has clinical utility. Mixed depression without psychomotor agitation, co-couple's criteria for mixed depression, 8 symptoms, has clinical validity. Co-couple's criteria for mixed depression were validated by Gabriele Sani and collaborators in 2014, just 1 year after co-couple's death. The clinical utility, the concept of clinical utility of psychomotor agitation is supported by the negative impact of antidepressants on it, and by being a precursor for suicidality, related or unrelated to antidepressants. Now moving to the clinical experience with what's called the non-DSM mixed depression. In our clinical practice, we evaluated many patients with long-standing refractory depression. That's to say, long-standing cycles of depressive episodes that don't remit using multiple types of antidepressants. All had been taking antidepressants for many years. All complained of psychomotor agitation, inner agitation, and irritability as central features. None of them had any history of hypomania or mania at all. The questions raised here were: are these cases of unipolar depression that need more aggressive antidepressant therapy? Are these cases of bipolar depression that need mood stabilizers? Or are these cases of what's called the non-DSM mixed depression? We were inclined to consider this consistent with what's called non-DSM mixed depression, thus tapered their antidepressants and initiated a small dose of an antipsychotic. Surprisingly, rapid and dramatic response took place in most cases. This finding is in line with some previous reports about the efficacy of small doses of antipsychotics in managing mixed depression, as you see. So, Franco Benazzi once said, in a study of his in 2005, the definition of mixed depression, which will better show the impact of treatment, is the definition of a choice in clinical practice. A golden rule indeed. Based on this notion, the non-DSM mixed features should be very important, and a scale developed to capture them is worthwhile. That is the Shahin Mixed Depression Scale, a self-rated screening test comprising 2 subscales, one of which represented psychomotor agitation as defined by the research diagnostic criteria from item 1 to item 6, with a cutoff score greater than or equal to 2. The other subscale matched co-couple's criteria for mixed depression from item 6 to item 13, with a cutoff score greater than or equal to 3. Item number 6, representing over-talkativeness, was shared by both subscales, so it could then be included in either context. From item number 1 to item number 6, item number 1, I am unable to sit still. Item number 2, I keep pacing back and forth. Item number 3, I keep wringing my hands. Number 4, I keep pulling or rubbing on my hair, skin, or clothes. Number 5, I have unprovoked outbursts of complaining or shouting. Number 6, I feel very talkative. Checking yes to any of them was considered a positive score. Item number 7, representing inner agitation. It was further subdivided into 3 sub-items, A, B, and C. A, I feel too much energy pent up inside my body like I am going to explode. B, I feel a violent force inside me as if I wanted to smash everything. C, I am unable to relax because I feel so tense. You know, inner agitation or inner tension or psychic agitation has an overlap with depressive anxiety. So we wanted to better clarify this item by further subdividing it into 3 sub-items. For a positive score, A or B plus C had to be checked yes. Item number 8, representing racing or crowded thoughts, was further subdivided into 2 sub-items, A and B. A, racing thoughts. My mind is racing so much that I cannot focus on any one thing. Number B, crowded thoughts. I have so many thoughts happening all at once that my head feels like it is about to explode. Checking yes to any of A or B was considered a positive score. Note that there is a difference between what's called depressive rumination and racing or crowded thoughts. The matter in depressive rumination is the content, worry and anxiety, depressive thoughts. But the matter in racing or crowded thoughts is the stream, which is tormenting to the patients. Item number 9, representing subjective or objective irritability, was further subdivided into 2 sub-items, A and B. Number A, I have unprovoked feelings of rage, subjective irritability. Number B, I am so irritable that I shout at people or initiate fights or arguments, objective irritability. Checking yes to any of them was considered a positive score. Number 10, representing wretched description of suffering or frequent spells of weeping, was further subdivided into 2 sub-items. Number A, I describe my suffering so dramatically and exaggeratedly that others notice that. I have frequent spells of weeping, A or B. Checking yes to any of them was considered a positive score. Number 11, representing initial or middle insomnia, was further subdivided into 2 sub-items, A and B. Number A, it takes me longer to fall asleep. Number B, I wake up in the middle of the night and I can hardly go back to sleep, middle insomnia. Checking yes to any of them was considered a positive score. Item number 13, representing absence of signs of retardation, was further subdivided into 2 sub-items, A and B. A, I move so slowly that others notice that, retardation. B, I talk so slowly that others notice that, retardation. So checking no to any of them was considered a positive score to indicate absence of signs of retardation. Finally, item number 12, representing mood lability. I go back and forth between feelings of sadness and feelings of happiness, mood lability. Checking yes to it was considered a positive score. Regarding the instructions, by the way, please read each statement carefully and decide whether it describes what you have been experiencing over the last week, including today. only the last week. Only check yes to the statements representing experiences that frequently, not rarely, occurred during the last week, including today. Something that is worth mentioning is that we want to be more sensitive when capturing these symptoms rather than more specific. With this, we come to the end of our lecture today. Thanks for listening.